All right, so as disclosures, I'm going to go a little briefly in just bone graft as we've been talking about. Obviously the roles are enhanced biological repair, fill the voids that we've been talking about, and enable bone fusion. Just briefly, we know the type of bone grafts. Osteogenic examples would be the autograft we've been talking about, osteoinductive, commonly known as our bone morphogenic proteins, and then obviously osteoconductive, which would be a lot of our cancellous cortical chips, calcium phosphate products. NanoBone, as we know, is a little different. Being a synthetic product, the difference in using the nanotechnology is the fact that it's actually at a nanoscale. So the hyaluronic acid is actually equal to that size of human bone. When we talk about it, it's really this ASG, this amorphous silical gel that really is the, what allows us to be such a powerful product. Essentially what happens, it allows this angiogenesis, attracts the stem cells and osteoblasts, which lead to the bone forming cascade. And then I'll go over how that forms in as early as 10 to 15 days as compared to what we typically would see as 4 to 8 weeks in other uses. The way it does that, it binds these growth factors that stimulate bone growth formation. And as was mentioned earlier, the few 100,000 cases have been done in Europe and more being done in the US with a 10-year history of use. So the key again is the nanotechnology being a similar size, chemistry, and morphology. I think as the hyaluronic acid is really what the key factors are. If you look at the actual size breakdown, you're talking about 3 by 50 nanometer wafers. So it's actually thinner than an actual DNA strand, which is pretty impressive. The surface area was mentioned earlier. I think that's one key that helps the nanobone be so powerful. So essentially this ASG holds all these nanocrystals in place. Because it's so hydrophilic, it allows it to release. What happens is then it triggers the angiogenesis, as I mentioned, and then that undergoes a cascade into the autologous extracellular matrix formation. So this chart, I think, is really key in showing the breakdown, how that happens. You can see on the left, you have the silical gel matrix and how that breaks down over time, this scale being about 15 days. And then the key factor is, I think, this autologous extracellular matrix that forms, which typically goes on the remodeling stages that can take much longer than the 10 to 15 days that we see with the nanobone. This bone formation cascade, as we know it, typically would take anywhere from 4 to 8 weeks, sometimes longer, depending on the host. The key thing in this repair and why we think that allows the healing process to occur so much more quickly is you're moving this repair from 1 to 4 in 15 days as compared to this production of the ECM, which would typically take anywhere from 4 to 8 weeks, so much, much quicker. Now, obviously, I'm not promoted as being osteoinductive, although the publications would support it. The FDA obviously doesn't allow that claim, so ARTOS does not claim that nanobone is osteoinductive. So you heard about the putty, which is probably more commonly used, I would think. At least in my hands, I typically use the putty or use the quick delivery system. But there also is a granulate option. I think we can ask those that may know better than I do which one is more preferred. But in my hands, I typically use the putty more frequently. So going over nanobone and trauma, I'm going to present a publication from 2016 out of Europe. It basically looked at clinical results comparing complication rates with historical outcomes using iliac crest autograft. They used it just alone. And so I think that's a key variable. As we know in other products, whether it's cancellous bone chips or maybe even a BMP, surgeons typically will mix that with other substance of an autologous bone graft. This typically is used alone. And so this study and the study I'll touch on that we're presenting at the OTA in this fall, hopefully, will essentially go through that. It was a prospective enrollment. They had about 67 patients. You can see the breakdown, men and women. Most of these were acute cases, but they also did include some of subacute cases. The age variability was pretty wide, young age to 83, and they essentially followed them up at 1 week, 6 months, and 12 months. These were mostly lower extremity trauma cases, which I think in my experience is pretty much the same. A lot of these for me are going to be tibial shaft defects from open fractures. Theirs were tibial plateau fractures, as well as others. These are some of the, one example from that particular case was an open, you can see a very large area of bone defect in the tibia. They did some staging, kind of masculate technique, if you will, which I'll go over a case that we did something similar, just not as large a defect as this one. But you can really see in this case, after they removed the beads, just using the standalone bone graft, the amount of bone that they were able to obtain in this patient, I think is very impressive to the utilization of NanoBone in trauma. The results at 1 year, 90% completely healed. Our results are very similar, 100% healing rate in tibial plateau fractures, 100% healing rate in calcaneus fractures. They did have early intervention at 1 year, used alone again with the NanoBone. Their conclusion essentially was, in their findings, were very equivalent to autograft and fracture healing. So I'm not going to present the data today, but this is a abstract that was accepted, will be presented at the OTA, essentially our experience using nanotechnology as standalone bone grafting. And we combined our series in both open fracture bone defects and non-unions. And so the key basis of the study was to really review our outcomes and complications of open fracture defects and non-unions that we utilized NanoBone only. Our numbers have grown since the original submission, but 17 patients were included in this abstract submission. And essentially, our data showed very low complication rates, very high union rates beyond 90 percentile, and early healing. A lot of the early healing we saw, as I'll show the example here, as early as 6 weeks, both clinically and radiographically, which I think is key. As we know, sometimes they don't always go together, but in these patient outcomes as measured, both of them correlated with clinical and radiographic healing. So with that in mind, I'm gonna present 2 cases. This was a soccer player. He had a Type IIIB open tibia fracture. And so essentially, these are his injury x-rays. His opening is essentially on the medial aspect. I apologize, I don't have any clinical photos of that. His initial treatment was irrigation debridement of the open fracture, reduced it, and then we went with primary intramedullary nail fixation. He did undergo a secondary irrigation and debridement. You see a wound vacuum primarily. He did need some soft tissue coverage from our plastic surgeons. The staple line kind of goes over the amount of his skin defect, just to give you an idea. These are after a second debridement. You can see the antibiotic beads dispersed in there. Not a large defect as the previous case that was shown, but this was one of my earlier cases using NanoBone. I think now, seeing the ability of the product, my extension use of it in larger defects has come into play. So after 6 weeks, typically in any open fracture that we're in bone graft, I do bone biopsies and cultures just to ensure that there's no potential of infected material or dead tissue. Those came back negative for infection. So once we get those results, which is typically 48, 72 hours, they do return to the OR with negative test results. And then that's when we did NanoBone 5 cc's. And then these really are just his 6 weeks post-op, essentially healed, returned to sport after this visit. So all right, so this one is a little more extensive. 52-year-old male. He work-related, fell from large height. All the force came down his elbow. Large clinical defect of soft tissue loss and muscle loss on the posterior aspect of his humerus. On this, essentially what I do sometimes with the extent of injury, I'll do initial X-fix, debride the tissues, irrigate, and then return another day for their fixation once I feel that things are debrided and cleaned well. And then this essentially is post-ops, and you can see he's got a large column defect here, primarily just from his open fracture. Wound vacuum once again, because he did need some soft tissue rearrangement and skin grafting from our plastic surgeons. And so as common with these, I would let the soft tissues mature. And then 6 weeks later, similar thing. You can see the defect obviously still present. He has some good healing at the joint already. But with this defect, again, same protocol, bone biopsies, cultures, as long as those are negative, then we do the bone grafting. With this, we did NanoBone 5 cc's just in that lateral column. And essentially at 6 weeks post-op from his NanoBone bone grafting, you can kind of see the amount of remodeling consolidation that he has. So those are two examples of open fractures that I think are in trauma, at least sometimes more devastating, because you have a lot of periosteal injury, soft tissue injury, bone insult. And so in those aspects, these are just a couple of the cases that I've utilized the NanoBone. What questions do you have?